Okay.
Okay, guys. Today we'll talk about pulmonary function tests. Do you see an inflammatory pulmonary diseases? Do you see that the slide?
Yeah, we can see it.
Very good. So let's go back. You remember this slide from the pathogenesis? It is, you see the mechanism of diseases. Inflammation is a big part of it, right? So we have the normal human body and organs. The etiological factors that can cause disease affect that body, so that body reacts. We get tissue response, and the important tissue response is inflammation. So obviously, inflammation is a very important mechanism of disease in humans. We'll talk about how inflammation affects the lung today. And we see that inflammation is acute and chronic. And acute inflammation is represented here by pneumonia, which is the inflammation of the lung due to infection. And a lot of diseases here are chronic inflammation associated with some repair and fibrosis. All right. So these disorders are characterized by inflammation, as we said. And what we have here are lung tissues and airways. So the inflammation is going to affect the lung tissues and airways. And as we said, the development is due to that inflammation pathogenesis. And then it's due to various etiologies. As we talked about the etiologies, external, internal, and we can talk about external here like infections, allergens, pollutants, and the autoimmune reaction for internal. So we have the external and internal causes of diseases represented here in the pulmonary inflammatory diseases. What are the examples of inflammatory pulmonary diseases? All of us know the bronchial asthma and the chronic obstructive airway disease. And pneumonia is a representative of acute inflammation, like a classic example of that. The symptoms the patient presents with, as we talked about what is disease. Disease has a specific pathogenesis, certain etiological factors, and it has symptoms and signs and progression or prognosis. So the symptoms here are cough, dyspnea, which is the difficulty of breathing, wheezing or rhonchi when you put the stethoscope and listen to the lung, and chest tightness or chest pain. So we need, of course, the respiratory system as any other system in the body is very important for the oxygenation. So we have to work effective management, reducing the inflammation, like we use corticosteroids here, and to control the symptoms. If it's like bronchospasm or in bronchial asthma, you have to relieve that using the Ventolin and all of those agonists, sympathomimetics, and address the underlying cause of any, if it's possible to address the underlying cause. So there are two main categories of the pulmonary disease, inflammatory pulmonary diseases, I mean, because we are concerned here with the inflammation and inflammatory pulmonary disease. We have the obstructive lung disease and restrictive lung disease. What does it mean? Obstructive means there is an obstruction, and it's usually affecting the airway, either the major airway, the big airway, or the small airways. And this is represented clearly by bronchial asthma and also by chronic obstructive lung disease. Because like obstructive means the classic example of obstructive lung diseases are chronic bronchitis and emphysema. There is usually a mixture of these two subtypes. It starts as chronic bronchitis and becomes emphysema, or sometimes it's emphysema and the alpha antitrypsin abnormalities. So emphysema basically is like affecting the alveoli mainly, but there will be an element of obstruction. So it's still obstructive airway disease or pulmonary disease. Restrictive mainly the fibrosis. We call them interstitial lung diseases. And the interstitial lung diseases are characterized by fibrosis. And they have different types. Pneumonitis due to hypersensitivity. Again, hypersensitivity and allergy is an extrinsic cause of disease. And idiopathic versus secondary fibrosis happens secondary to some drugs like amiodarone, and secondary to allergy or allergens or pollutants, sometimes pneumoconiosis and all of that stuff, causing interaction or reaction in the interstitium, in the lung interstitium, that ends up with fibrosis and restriction of the lung inflation. So if you have fibrous tissue in the interstitium around the alveoli, as we can see in the next slides, this will restrict the distension and inflation of the lung. We call it restrictive lung disease. So we have two main categories of lung diseases: obstructive, that obstruct the airway, blocks the airway, or restrictive, restricting the movement of the lung. Any questions so far? No. Okay. So what is the pathological picture or pathogenesis of inflammatory pulmonary disease? Each disease will have some characteristics or some pathological features. And each disease will have also some different underlying mechanisms. But in general, all of them, the generalized picture of that is the inflammation is the main feature of the disease. And as we know, inflammation is actually a defensive mechanism. But if it's dysregulated, it can be chronic, as we saw in that slide. Like, the inflammation can resolve or can proceed to organization and fibrosis. And if there is some dysregulation, means we can see the dysregulation in these diseases when we talk about each disease. Let's start with bronchial asthma, which is the most common respiratory disease and most important for you, as it has a big immunological cause or immunological mechanism. Since we are concerned with immunology here, we can talk more about bronchial asthma as an example of pulmonary disease, obstructive pulmonary disease. So bronchial asthma is characterized by hyperresponsiveness. As we said, the allergy is hyperreaction or hyperresponsiveness to normal stimuli, like allergens like dust mites. They are everywhere, all over, and nobody gets reaction to that, except if you are having predisposition to that, like genetic predisposition or something, as we talk in the next slides. So it's hyperresponsiveness to allergens, which are normal materials or normal things present around us, or usually make it this way. Sometimes people get allergy to cold air. Just exercise or cold air can predispose or bring up asthmatic reaction, hyperresponsiveness. So that hyperresponsiveness causes inflammation at the end, because it's recognized by the body as a foreign material or foreign or irritant, and the body reacts to that irritant by inflammation, as we talked, and this inflammation brings up the bronchospasm. So ultimately, you have the bronchospasm and airway obstruction. This thing is acute, but it can be chronic, of course. Like if it is repeated, it's going to lead to chronic inflammation. So pathologically, the bronchial asthma will be characterized by airway remodeling in the long run, which is like remodeling of the airway. The bronchi becomes hypertrophic. The smooth muscle cells becomes hypertrophic and produce a lot of mucus to dilute that irritant. So we have mucus hypersecretion, and this we'll talk about that histologically, like goblet cell hyperplasia. So goblet cells which produce the mucus. So we have, when you get exposed to just cold or air or dust mites, you're gonna get a lot of mucus secretion, what we call it hypersecretion, which is not normal. Normally, the respiratory epithelium is ciliated and produce mucus. The mucus will be moved outside the body and expectorated. So you end up no reaction normally. But in this case, the reaction is exaggerated or dysregulated. So you're going to get, we'll talk about the pathogenesis in more details when we talk about the cellular mechanisms of this bronchial asthma. So we will end up with some infiltration of inflammatory cells like eosinophils and stimulation of the mast cells, which are like inhabitant or normally present in the airways. We talked about coronary obstructive pulmonary diseases, and chronic obstructive pulmonary diseases, COPD. And we said there are two subtypes, and the story starts here with the particulate matter, the PM, especially the smoke. So it starts with the smokers. They inhale the smoke, and this leads to progressive airway limitation. Like due to inflammation of the bronchi become not dilated enough to allow for inspiration and expiration initially, and then inspiration. We're going to get limitation of the airflow. The pathological findings here are destruction of the alveoli in emphysema, as we talked. We talked about the alpha trypsin and antitrypsin abnormality. And this destruction will be here in this particular case due to inflammation and reaction to the smoke, the cigarette smoking. And this usually has some degree of inflammation of the bronchi, which becomes chronic. We call it bronchitis, chronic bronchitis. So chronic bronchitis and emphysema are usually combined in the chronic obstructive or pulmonary disease, and they produce that ventilation problem. So the smoke is going to damage with the inflammation. It's going to damage the ciliated epithelium. And meantime, as we talked about in bronchial asthma, about hypersecretion of the mucus. So here again, and this results in obstruction of the airway and reduced exchange. If you have like thick mucus in the bronchi and the airflow is not going enough to the alveoli, and then there is no enough oxygen to diffuse, and then you have the alveoli are broken, destroyed, so there is no effective wall in the alveoli for exchange. You end up with a problem in the exchange. The gas exchange is the main function here of the respiratory system. So gas exchange includes oxygen inflow and carbon dioxide outflow. So both are going to be affected. And people talking about pink buffer versus blue bloater, where the carbon dioxide gets retention and the person becomes more blue. Okay. So again, inflammation, as we said, the most common inflammatory pulmonary diseases are bronchial asthma, COPD, and then pneumonia. Pneumonia is just an infection. Infection it's either bacteria, viruses, or fungi, and it depends. The fungi, a lot of fungal infections or inflammation is like endemic in some areas of US. Viruses are most common, like we heard about like respiratory syncytial virus and all of that stuff causing pneumonia, pneumonitis, or inflammation of the lung. And bacteria, the strep pneumonia is the most common, the most famous organism actually. But of course, pneumonia can be either diffuse or bronchopneumonia or localized. There are a lot of classification pathologically and even etiologically. We call it sometimes community acquired versus hospital acquired pneumonia versus immunosuppressive diseases, pneumonia, so on. So pneumonia is like a vast spectrum of infection of the lung, and it has different pathological and etiological factors. And as we said, inflammation will be characterized by dilution of that irritant. So we will have fluid. That fluid is going to go inside the alveoli now because you have the microbe or the organisms inside the alveoli. So the fluid seeps from the blood vessels into the alveoli and blocks them, and that causes consolidation of that lung. The consolidation is like the lung normally contains air in the alveoli. If it becomes fluid, and then inflammatory exudate and inflammatory cells bore inside these alveoli, so we're going to get consolidation. So the consolidation, if you remember from your pathology, I don't know if you studied pathology so far or not, but means we go into red hepatization of the lung due to the RBCs pouring inside the blood itself. So the red hepatization, the lung becomes like a liver when you cut section, becomes like back towards the RBCs. Usually it's one lobe, so we call it lobar pneumonia. It's not the whole lung, it's one lobe of the lung, usually, and it consolidates and affects the gas diffusion, of course, because now the gas has to diffuse through blocked alveoli with fluid and packed with cells, and then even the congestion in the capillaries, you have like big space between the air and blood. The oxygen has to flow all that barriers through that all barriers, and then the carbon dioxide has to again diffuse through that barrier, so you get gas problem and hypoventilation. All right, so if there's disruption of the gas exchange, can lead to respiratory distress, of course, and hypoxia, and it has to be treated promptly because it usually comes in the old age. So all the frail people will have this pneumonia, and you have to treat promptly so they can recover. And usually it ends up now with this antibiotic era, it ends up with resolution. So the lung clears up and everything becomes okay. All right. So we talked about pathophysiology before, and we said that the pathophysiology examines the etiology and pathogenesis and how they interact to affect the whole function of the body systemically and the function of different organs and cells. So this is that we call pathophysiology, and pathophysiology is going to be a very important big part in your study going forward in the medical school, because its disease will have its pathophysiology before you go into symptoms and signs, the clinical manifestations, and then treatment. So you need to know what is pathophysiology of each disease. And research-wise, we need to identify the biological markers and cellular and molecular mechanisms of each disease to find out if we can develop something to, like, markers to point to the pathogenesis or the etiology or the prognosis of the disease, how we can treat it. If there are some molecular targets, you can target and create novel or new drugs. So as we talked about, we're gonna talk about the bronchial asthma, which is the most important, like, common disease and relates to immunology. And this is an example of pathogenesis which is applicable to other pulmonary diseases, but it's a little more complex than others here. And as you see here, on the cellular level, bronchial asthma, we talked about hypersensitivity and airway obstruction, but the pathogenesis, how this happens on the cellular level. You have the allergens, like the pollens, like the mites, the dust mites, which enter and exit every time in our lungs, and nothing happens. When the person is predisposed, those antigens are taken up by the dendritic cells. We call the dendritic cells from immunology the antigen-presenting cells, and they present them to the lymphocytes here. And actually, CD4 T helper cells, we have two helper 1 and the T cells, T helper 2, TH2. And if this person is predisposed genetically to asthma, usually a child, they produce T helper 2 more in reaction to that dendritic cell antigen presentation. So this produces T helper 2 rather than T helper 1 cells. So in this condition, the T helper 2 cell is gonna produce interleukins, which are molecules for the cells to communicate to each other. And this interleukins, like interleukin 5, 4, 5, and 13. And 4, 5, and 13 produce stimulation of plasma cells, or they induce the plasma cells. So those plasma cells produce antibodies. One of them is IgE, and the IgE interact with the mast cells, which are the inhabitants of the airway here. And those mast cells start to degranulate, and these granules from them contains histamine, leukotrienes, prostaglandins. And in the meantime, interleukin 5 stimulates or induces the eosinophils, the allergic cells, and they also produce cytokines and leukotrienes. All of that products, histamine, leukotrienes, prostaglandins, other cytokines, are pro-inflammatory, and they produce, and pro-allergic. We'll see what they produce, and this is the pathophysiology now. Due to this big amount of interleukins and leukotrienes and prostaglandins, the bronchi are gonna respond with acute response and chronic response. The acute response is bronchospasm. So the spasm of the bronchi causes this difficulty in breathing and also wheezing or rhonchi. Bronchial wall edema, it's inflammation. So edema is a hallmark of inflammation. And as we talk, increased mucus secretion, hypersecretion actually. So this is the acute response to all of that products, pro-inflammatory and pro-allergic products. And this becomes repeated like weeks, months, and years. This response becomes chronic now. So chronic response will bring the hyperresponsiveness of the bronchi with chronic bronchial wall inflammation, as we talk, and remodeling, airway smooth muscle hypertrophy and or remodeling. So if you think the acute response is gonna be like reversible, but gradually it becomes continuous, like either there is an allergen or not, the patient will have some degree of bronchospasm or bronchial obstruction. All right. And as we said, all of this is two airway obstruction, and this will increase the mechanical work of ventilation, breathing. So the patient becomes like difficult to breathe, to expel the air through against this inflamed, narrowed bronchi. So this will create more mechanical stress on the chest wall and diaphragm in the body, so to expel the air during expiration. So this patient ultimately will end with hypoventilation, and hypoventilation means less oxygen, more carbon dioxide retention, and respiratory problem up to respiratory failure. So in the status asthmaticus or in the severe case. Okay, then this applies to other lung diseases. If you think about them, you think about them in view of or perspective of pathogenesis and pathophysiology. Without further delay, because we are late already, go to the pulmonary function test. So to diagnose these diseases, or probably we can also use this pulmonary function test to gauge or test or determine the response to medications. So what are the pulmonary function tests? As you see here, the patient as the child here sitting inside that box, the glass box, and there is a mouthpiece where this patient is gonna blow air inside, and the technician is giving instructions and measuring. That computer is graphing and determining the various measures and parameters of respiration. If you close the door, the body change in the body volume will go and against the graph, against the, like in the older days, the drum which rotates. So you get graph of the pulmonary volumes. I'm gonna get into that. All right, so what we measure. So pulmonary function tests measuring airway size or flow in the airway. So either large or small airway. They measure the parenchyma. What parenchyma? We test the parenchyma. Parenchyma is interstitium. So we in the lung we have the airways and the parenchyma. Parenchyma is interstitium and alveoli. So we have tests for both. The interstitium mainly affected by the fibrosis. Okay. And the alveoli will be affected by emphysema and the bronchi, both chronic bronchitis and bronchial asthma. So those are the things we test in pulmonary function tests. You test the airway, you can test parenchyma, how it works, how it functions. And the parenchyma, as we said, or parenchyma is either alveoli or interstitium. And we can test also the mechanism of breathing, like the mechanics, the bellows, like the diaphragm and chest wall, the reps and respiratory muscles of the chest wall and the diaphragm. And we can test the vasculature as well, using the what we call it carbon monoxide diffusion test. And even the neural control, we can conclude if there is a neural control affection, because you're breathing, the lungs, we've been told to expand by the brain and the nervous system, central nervous system, to the degree of expansion and the rate, all are controlled by the master, the central nervous system. Okay. So what are the pulmonary function tests? As we said, the common tests are the standard tests when you tell any physician or any medical or healthcare provider about the pulmonary function tests. Those standard tests jump into their minds. Spirometry. Now the spirometry, you can do it either in a hospital or now there is can be done at home. Lung volumes, as we see that glass chamber, you can do the lung volume. And there is something called diffusion capacity. So the diffusion capacity is you blow CO, carbon monoxide. It's toxic, but it's a very small amount. It's not that toxic in the test. And you see how this carbon monoxide goes from that air the patient inhale to the blood. So, you will have an idea about the diffusion. Why carbon monoxide? Because it has high affinity to the hemoglobin, so it goes fast into the lungs, into the blood from the lungs. So this way, it's very sensitive. If this carbon monoxide diffusion is less, means the diffusion in the lung, which is the gas exchange, is less. Okay. So we have other tests, of course. There are very big list of pulmonary function tests, but we're going to focus on spirometry, lung volumes, probably some diffusion, but also you can do arterial blood gases. It's famous, but it's the blood test. It's not actually lung test, but it tests the gases in the blood, which is the end product of respiration, right? We have bronchoprovocation tests where you give a bronchoconstrictor like acetylcholine or its derivative like methacholine, and you make a challenge to if you suspect that this patient is asthmatic and you're not sure, you want to give this methacholine and see if the respiration is going to be affected. So exercise testing like the 6-minute walk test, and we have a lot of things. So these tests is actually the main idea is to classify the disease here. As we said, there are two types, obstructive and restrictive. And the pulmonary function test usually tell us if this is obstructive or restrictive. It's not very good in differentiating. We need like probably combination of this to know which type of obstructive, which type of restrictive. Okay. So if you see the lung volumes here, without talking about lung volumes, you're not gonna appreciate what are the pulmonary functions. So this is a graph from a patient sitting, breathing in and out. So the amount of air you breathe in and out at normal resting breathing, we call it tidal volume. This is around, we're gonna get two values. But for now, the tidal volume is the amount of air going in and out of the lung, normal breathing. So the amount goes in equals the amount goes out. So this is called tidal volume. If you breathe like above the tidal volume, like inhale more air, the air above the tidal volume until it reaches to the maximum, we call it inspiratory reserve volume. So we have tidal volume, inspiratory reserve volume. Then you exhale, tidal volume. If you exhale more than the tidal volume, this is called expiratory reserve volume. So any volume below the tidal volume, you can exhale is expiratory reserve volume. Do you think if you exhale the air to your maximum, you expel all the air in the lung? Any idea? Any suggestions?
No. You have the residual volume.
All right, perfect. So there is actually big amount of air in the lungs remaining. We call it residual volume. So the residual volume is the volume of air after the maximum exhalation or expiration, right? Those are the volumes, but actually we don't talk much about the volumes. The volumes are just for a study, for physiology study or something. We talk about the capacities. And the capacities are just like summation of these volumes, this volume plus this volume, like the tidal volume plus the inspiratory reserve volume, we call it inspiratory capacity. So the amount of air, you can just calculate this from tidal plus inspiratory reserve volume equal inspiratory capacity. It's confusing, but it's this way. Okay. The most important capacity here is the vital capacity. That's the one we use in the spirometer and everything. And the vital capacity is when this inspiratory capacity, when you expel with plus the expiratory reserve volume, gonna be the vital capacity. So the vital capacity is like actually 3 volumes added together. Did you get confused or not yet? So we have inspiratory reserve plus tidal plus expiratory reserve volume. This is the tidal capacity. All right. So you can measure the tidal capacity from that graph. If you expire, like exhale, this one, exhale the tidal volume, exhale the expiratory reserve volume together, you can measure the tidal capacity. And this is what we do in the spirometry. I will show you in a minute. All right. What is the total lung capacity then? It's the the vital capacity plus what remains in the lung. What the air we cannot move. We call it residual volume. So the total lung capacity is actually everything together, all the volumes. And there is functional reserve capacity, which is something just for completion here. That is the expiratory reserve volume plus the residual volume. Okay. Here are the actual values. The person is breathing, putting clip on the nose, breathing through that mouthpiece into that device. And this is the tidal volume. And then this is the inspiratory reserve. This is the expiratory reserve volume. And those are they are different by the way. And it's like male, they are different from females. And they are different according to the age, weight, ethnicity sometimes. So you have to standardize them, giving like percentage of normal for that specific person. Like you have to use a control comparable to patient age, weight, ethnicity, all of that stuff. So they usually differentiate between normal and abnormal according to the percentage or comparison between the control and the patient. Okay, this is the total lung capacity here, and this is the residual capacity. You see, residual capacity is actually more than 1 liter, which is a big amount of air remains in the lung. Okay, so now if we talk about spirometer or spirometry, we're going to talk about forced vital capacity. What is forced vital capacity? It's vital capacity when you force the air out, like breathe to your maximum speed. So this is forced. We call it's a vital capacity, but forced means it is performed rapidly as possible. All right. And as you see, the forced vital capacity and the forced vital capacity in 1 second, we actually exhale around 30% of air during the first second. So we call this forced vital capacity C1, means in 1 second here, that part. And then the breathing, the flow becomes slow till the end of expiration. And we inspire, we inhale again. You see? So keep in mind what is vital capacity and what is forced vital capacity is C1. And those are important measures for the spirometer, which is the most common test. Initially, this spirometer was like this in the old days, like drum moves up and down, and some pen here or marker writing on a drum which rotates. So you get up and down like the curves we see. And now it becomes a computer. So this patient is like breathing through that mouthpiece, and the computer generates all the values. So this is how it looks. You take deep breath inside, and then this is the expiration. You exhale. See? So the first second is like 30%, and then 70% for the rest of the test. Here is for 6 seconds. Okay? And now this curve generated by the computer is the correlation between the volume you exhale and the time. So that's the flow. Volume per time is the flow, right? And this is the flow. This is the flow at the end of expiration. So we call it here the blast and respiratory blast, forced vital capacity in 1 second, and then it continues until the 6 seconds slowly. Okay, what we measure for this parameter, as we said, FEV1, FVC, the ratio between this and this, and we're gonna know now why this is important, the ratio, and flow volume loops, like without going into detail, this is the loop, and this flow volume loop, we were talking about air against flow against time. Now we're talking about flow against volume. So this is the expiration here, and this is the vital capacity here. If this makes sense, right? So the curve, the inspiration is more regular than the expiration. Like this inspiration is like a curve, well rounded, nice. So inspiration is below 0 because you suck air in. When you bring the air out, it's positive value. And this shape of the curve is very important for respiratory clinicians to differentiate between different diseases, right? Okay, we'll make it simple. So as we said before, we can also, after we generate this loop, we can also test the response to bronchodilator. If you want to see the response of your drug, you give this drug to the patient, you measure, they will do spirometry before and after, and if it's better, means your medicine is working and the patient improves. Here the interpretations of the one, FEV1 and FVC. So in bronchial asthma, obstructive lung disease, when you breathe in, there's no problem usually. The problem with expiration, because when you breathe in, the airways is going to be enough with the negative pressure you create in your diaphragm and chest wall creates, so the air flows nicely in. Normally, during expiration, the airway gets narrower, normally. So that's why the expiration is prolonged. And the first second, the air goes very fast and then goes slowly. So imagine this patient has a bronchospasm, bronchial asthma. So when they take in, breathing will be normal. So the vital capacity is going to be normal here. Or maybe in the chronic disease, as we talk, it's going to be little less. But when they exhale, this is the problem. The FEV1 is going to be affected. Means the flow of the air inside within the first second. In the first second, it's going to be affected. Far less. So the normal ratio between FEV1 and FVC should be 70% or above, as we talk. Okay? If it's less than 70%, means there is obstructive lung disease. Make it this way. And if this is the take-home message, remember that FEV1 over FVC is going to be less than normal in obstructive lung disease. This is more than enough for today's lecture and the pulmonary function test. So how we differentiate between obstructive and restrictive? Any suggestion? It's in front of you. Just tell me. What's going to be affected? FEV1 or FVC or both? Tony,
FVC.
go ahead.
Sorry.
You're good.
FVC normally, and then that FVC, the ratio would help you pick.
Yeah. So if there's restriction, then the amount of air going inside the lung is going to be restricted, right? When you inhale. So you cannot exhale more than you take in. So when you inhale, the amount of air going to your lung is less because of the restriction, the fibrous tissue in the interstitium around the alveoli. So you're going to get less volume. Okay? When you exhale, of course, the FEV1 is going to be also less, and sometimes normal, because it's like the alveoli getting compressed quickly with the fibrous tissue. So that air in the first second is going to be even more. So let's say both decrease, but FVC is going to be decreased more than FEV1. So if you have the one above that line, the fraction, denominator, and all of that stuff, so that one becomes big, and this one is less, and this one is more, although it's less than the normal. So we're going to get normal or increased ratio. You see? So if you get normal or increased ratio, it is restrictive. It's 70% or more. If it's less than 70%, it's obstructive lung disease. Okay? Any question? Okay, if you all understand this, this is good. So we do pulmonary function tests in animal models. So we create animal model for research, usually rodents, mainly mice and rats, and we give them the dust mite and everything, and sensitize them and create a bronchial asthma, as we did in our lab, and then we can measure the pulmonary function to see if we created that one, what is the effect of so and so, the molecules and so on, and examine the molecules and molecular mechanisms. So same way we talked about pulmonary functions in human, this is going to be applicable to animals. Okay? But we need to do it a little bit different because the animal is smaller, the species differences, so some modifications. Of course, you cannot do it like in humans, you give instructions to the patient, so the patient follows, like take a deep breath, exhale slowly, rapidly. You cannot do this with animals. So this is the condition here, or how we have to modify it this way. If you want to get it more accurate, you probably need to anesthetize the animal, so under anesthesia. So there are variety of tests here. And then you have to intubate the animal, but the oropharyngeal tube. You can also ventilate the animal, but putting a ventilator to assist in the exact measurements of the tidal volume going in, you control. So those are the variable tests. So either the animal awake and not controlled, or the animal is anesthetized with the endotracheal tube, or the animal is anesthetized and ventilated. Means ventilator giving the air to the animal. So those are the types of tests we do in animals. And basically we test the same thing: tidal volume, expiratory reserve, vital capacity, VF, V1, but in different ways than humans. Okay, so we use the large animals like pigs and others also, but everything has its own pros and cons as we will talk about the animal models. Okay. As this is what we talked about, like the non-invasive method means technique without any restraints to the animal. And this is, you control nothing in this. There is no control in that. And the example of this, the barometric plethysmography, okay? Or non-invasive, the animal getting restrained. We see it, the picture now, we put it in a plastic tube. In the head, you put the head out and you do the plethysmography. So the plastic tube measures the volume of change of the volume of the body and gives you a result. Or you force the air. And so this is going to be more little control. So this is, we control something here. Animal is awake. The invasive, when the animal is anesthetized, sleeping. So you put oropharyngeal oropharyngeal intubation, intubate the animal through the to the mouth. Like this tube goes to the trachea, and you do some pulmonary maneuvers on intubated rats, or even surgical implantation of pleural pressure sensor. You give anesthesia and put a sensor inside the pleura, open the chest, small incision, put that one, and record while the animal is conscious. And you can do tracheostomy, open the trachea here and put the tube for ventilation in the trachea. So the animal, you cannot like bottom out piece and ask the animal to breathe. So you have to put somewhere where the animal should breathe, like inside the trachea. And this is invasive. So invasive, controlling everything up. This is how we do it. You put the rat inside this plastic tube or the mouse, and you connect everything, the drums and everything, which measures. And here, even you can give aerosol like the allergen and everything. And this, see the plasmography and the piston measures, like adjust to the body wall. And then this device is gonna measure the change in the volume of the chest. So you can have the lung volumes. All right, basically. Those are the graphs. This is with acetylcholine aerosol, and with this is with normal air. Inspiration, expiration, tidal volume, compliance of the lung. You can measure all of that good stuff. And here's the invasive, where the animal is under anesthesia, and the tube here, oropharyngeal tube, goes into the lung, and the animal here, the rat. This is the actual one, and this is the diagram showing everything, the vacuum, so you can control the breathing. And here is the aerosol, you put acetylcholine or whatever. And this is a photometer, measures everything with them. So the common techniques in animals, we can see same thing: spirometry, forced oscillation technique, negative pressure, forced expiratory technique, pressure volume curves, as we saw the curve in the lung, the loop curves, head out, as we see that, so that rat or mouse with the head out, and the plethysmography that measuring the body volume and change, and other methods to determine the compliance and the dynamics of that compliance. Okay, with that, we're gonna end that talk. Any questions? No questions? It's a complicated subject. All got it? All right, then that's great. Okay, I'm gonna stop sharing and we're gonna say goodbye to everyone.
All right, thank you.
Thank you, Dr.